So hi, I'm Amy Dooley. I'm the Regions Hospital Sane Program Director. So I work with the Sane nurses to provide excellent forensic care to our patients who've been sexually assaulted or experienced sexual violence.
So can you help those of us in EMS better understand SANE versus SART programs?
Yeah, so SANE programs and SART programs, really there's not a huge difference. It's really just what they call the program. So you'll hear a couple different names from different programs across the Twin Cities and in the western Wisconsin area, but they all provide very equitable services. At Regions we call our nurses SANE nurses, other places they call them SART nurses, but it's all pretty much the same thing.
So for EMS providers, which hospitals actually have SANE nurses?
So pretty much any hospital in the Twin Cities or even the western Wisconsin area, so even the rural hospitals have access to SANE nurses. So there's a couple different programs in the Twin Cities that provide care to the different hospitals. So Regions Hospital obviously has a program, and we provide care to Regions Hospital, Lakeview Hospital, as well as St. John's and Woodwinds Hospital. But then there's also a program at the Alina hospitals, and there's a program over in Hennepin County that covers quite a few hospitals over there. And then in western Wisconsin, the St. Croix Valley SART program covers all of the hospitals on that side of the river. And so that is pretty much any hospital you're going to go to is going to have access to some program.
Will all patients admit to being assaulted?
Yeah, I mean, I think if you suspect that something's happened, it's okay to talk to the patient about it and ask them. And I think the best way to ask that question is just to be as gentle and kind and blunt as possible, and just say, did you get sexually assaulted, or did something happen sexually that you didn't like? And patients might not always disclose this right away. So if you suspect, or if you're concerned that there could be a crime scene present when you get to the site, just be careful not to disturb too many things. Always patient care comes first. So make sure that your patient is taken care of. And if that means you have to disturb certain things, do what you have to do. But if you can try and preserve things, that's a good thing. If you feel like you need to get the police involved, or if there's police on site, feel free to speak up and let them know what your concerns are. And then really the biggest thing I think with treating patients who have undergone sexual violence is just to really be mindful of the trauma that they've gone through, and understanding that they are not going to react in a stereotypical way. Some of them may be hysterical, some of them may be shut down, some of them may be belligerent, and it really is not there's not a one way that we see all the time that patients might interact with medical professionals. And so really giving people time and understanding is the best thing that you can do in those circumstances.
How long after an assault can the patient be examined?
Then, the sooner we can figure that out at the hospital, sometimes providers forget to ask, and it's not for 2 hours after the patient gets there that we even figure something like that out, or sometimes not until the next time they come to the hospital do they disclose, which is okay if the patient wasn't ready to disclose, but I think it's better if we can know from the onset, so it just helps us to give the correct and best care to the patient. If we get that, in the initial report. Yeah, I think there is. I think there's value in that, because it helps us when you get to the hospital to have that in the initial report, so that we can know kind of what care this patient is going to need, and know which providers we're going to need to call in. The SANE nurses are all on call, so they're not on site at the hospital, so it takes a bit of time to get them to come into the hospital. And I think too, not every patient is going to be ready to disclose, and so they may not disclose to you. But some of them are just waiting for someone to ask the question, and it's something that they're not going to necessarily volunteer. But if you ask, it's almost a relief, I've heard some patients say, that someone asked them, because it opened a door that they weren't ready to open themselves. And so, I think it's fine to ask. If you have a suspicion that somebody's been assaulted, just ask them. Be as kind and as gentle as possible, but you can be blunt and just ask the question. And if the answer is no, then the answer is no, and that's fine. I wouldn't push them. If you suspect that maybe something's happened and the answer wasn't maybe clear when you ask that question, it's okay to tell that to the nurse or to the doctor when you get to the hospital too, that you're still really suspicious, maybe something happened, but they didn't come out with that to you. So, I think it's always better to have more information rather than less. And it's an uncomfortable question sometimes, but it's a necessary one, I think, if there's suspicion there.
So how does EMS prepare a patient for what they're going to encounter once they arrive at the hospital?
Yeah, so a patient who has been sexually assaulted is actually going to get a higher triage level at most hospitals than than someone who has been just, run-of-the-mill assaulted. And so that's the idea, that we try and keep them out of the waiting rooms as much as possible. Now with COVID, that's very difficult. But we do have some other things in place through different hospitals, where some triage algorithms where we try and shunt these patients to other waiting rooms or to other areas where they can wait for their care if there's going to be a long wait. Because again, we don't want to be traumatizing patients or re-traumatizing patients by having them, sit in a loud, crowded waiting room after they've been through such a traumatic event. So I think the most important thing for EMS for helping these patients get triaged to the right level in the right place is just, if you do know that a sexual assault has happened, making sure that the triage nurse or the provider, whoever you're talking to, the charge nurse, knows that that is the case, because that will change how quickly they get roomed or where they get roomed to in what area of most hospitals. Yeah. Well, so I think as EMS providers, the big thing that you want to be keeping in mind is that your job is to get them where they need to go. And so it's okay to, ask preliminary questions, and really you're trying to make sure that they're, what happened in a vague sense, that they're safe, that there's not, other injuries that need to be attended to. But you don't have to go and get the entire history of things. In fact, that could be a little bit traumatizing to some patients, to talk about the whole history to you, and then the whole history to the doctor, and then the whole history to the Sane nurse. And so even as medical providers, when I go in to see a patient, I will ask very vague terms of, well, what happened to you, to get an idea so I know what medical things I need to be treating. But I don't necessarily ask all of the details, because I know they're going to be asked those questions from the Sane nurse, and I don't want to re-traumatize them. So you don't have to go into too much detail when you're asking these questions. And you want to be careful not to force them to disclose or to talk about things that they may be uncomfortable about. Primarily, we do see men who come in who have been sexually assaulted. That's not uncommon. But primarily, the majority of these patients are going to be women, and many of our crews are mostly men, or predominantly men, which could have an interesting dynamic if they're feeling like they're being forced into disclosing or whatnot. So you just want to be gentle, and if you feel resistance to questions, it's okay to stop questioning. You don't have to get all the information.
So during these COVID times, and in the situation that faces these patients with waiting times, such as waiting in triage or the difference between a consultation room, should someone stay with the patient?
I think it's obviously understandable to feel for this person and want to provide them with kind of an extra TLC, extra level of care. I guess in most hospitals, there's not unless there's some sort of a suicide risk or something else, we do leave people, unattended or unwatched, during the time that they're waiting for their assessments and whatnot. I guess I would kind of play that by ear with different patients whether or not you feel like they're safe to be by themselves, if they need somebody to be, with them at the bedside. But most patients are going to be safe to leave by themselves and going to be, it's going to be okay to hand over care and, say your goodbyes.
How long after an assault can the patient be examined?
At the Regions Hospital program, we use 10 days. So it's about 10 days, or we will examine someone and do a SANE exam 10 days after an assault has happened. Different other programs use different numbers, and you'll forgive me, I believe the Alina program is 8 days, and I think the Hennepin program is also 8 days, but they may have changed to a longer time period as well. And that has to do just with departmental protocols and whatnot. There's less evidence that can be collected after, 5 to 10 days, but it's still, there's benefit from having the SANE nurse provide the care and the support and the connection to resources that is part of the SANE exam.
What's the one piece of advice you'd give EMS providers as a takeaway as far as dealing with patients who've been sexually assaulted?
So I think one of the things that we talk about a lot in sexual assault care or trauma care is this idea that the patient has undergone a traumatic experience, and we like to talk about trauma-informed care. And really what that means is understanding that the psychological basis of what goes on in your brain after a traumatic experience creates very different outlooks. And so things that you see on like CSI or SVU, where they have this, profile of this is what somebody looks like when they've been sexually assaulted, really don't prove to be true in actual reality. People can be very different ways. They can be, happy, they can be sad, they can be very closed off, they can be combative, and some people are ready to disclose, some people are totally in denial that anything happened. I think one of the big questions that I hear a lot from patients is they'll tell me this horrible story of an assault, and then they'll say, was that rape? And it's like their brain can't even comprehend that is, that's what happened. And so I think as providers, whether EMS or in the hospital, we just need to be aware that everybody's at a different place, and that they may not be ready to process what happened. And we have to be respectful of that, and we have to be just compassionate in understanding that what our preconceived notions may not actually be what the patient feels like or what they look like. And so, I think it just to challenge our own conceptions of what sexual assault is, what rape is, and what a rape victim looks like, and it's not always that stereotype.